And
you please start over here.
बस यही है ना, इससे हो जाएगी ना मेरे ख्याल में, है ना.
सर थोड़ी सी चेयर चेक करना. Done, sir. So we are starting in 10 seconds. 10 seconds start.
ठीक. वो एक मिनट, जो लाइव ट्रांसमिशन है ना वो 2:30 पे टाइम देखो.
लाइव कर दे.
चलो. Okay. Good afternoon, viewers. I'm sure you are enjoying the sessions on MasterClass for the last 3 or 4 sessions. Today we are going to discuss the inhalation therapy, the basic principles and perspectives of administration of drugs by the inhalation route, you see. The inhalation route has become important in the last century or so, and different type of drugs have been administered by this route. As you can see from this comprehensive slide which was published some times ago in the Pharmacological Review, bronchodilators and glucocorticoids are the two most commonly used drugs, then chromones, anti-infective agents, antimicrobials, DNAs, mannitol, surfactant, pulmonary vasodilators have also been administered by the inhalational route, and there are multiple kind of methods of administration and different type of diseases for which these drugs have been used, and both local and systemic. So we'll discuss these issues in little more detail in the next few slides. This is an important slide on pharmacokinetics of inhalation versus injections, you see. I think the conclusion here is that the inhalation delivery involves, the inhalation therapy involves pulmonary delivery of drugs through airway route, and you can see here that the pharmacokinetics of inhalational drugs, they almost parallel those of intravenously administered drugs. I think that is a big kind of observation which has changed the method of delivering drugs, especially to the lungs, even for emergencies or for routine maintenance treatments, you see. Now, what are the advantages of the inhalational route or direct pulmonary delivery, you see? That's what it implies, that it is a direct delivery to the lungs, you see. It is a kind of topical delivery in one sense because it delivers high concentrations directly to the diseased site most of the time. These are the airways and sometimes the lung parenchyma as well. So there is a rapid clinical response. There are minimum risks of systemic side effects because the drug is minimally absorbed in the blood. It bypasses the barriers to therapeutic efficacy such as the post gastrointestinal absorption and the first pass metabolism in the liver, and it achieves a similar or superior therapeutic effect at a fraction of the systemic dose. So the dose used is much lower, and therefore the side effects are much less, you see. I think it would be interesting to go into the history of inhalation, the mythological kind of concepts as well as the historical concepts, you see. Possibly the inhalation route originated from the Greek mythology, which has become, I think, which is quite famous now. Pythia, the priestess of the temple of Apollo of Delphi, they say she used to deliver prophecies in a delirious state which usually came out to be true, you see. And these these kind of prophecies were delivered after inhaling vapors from the Mount Parnassus, which you can see below, and kind of the priestess Pythia. So I think though effects were inhalation, the effects of inhalation were known perhaps since then. In our own history, in Ramayana, they say the medicinal herb, the Sanjeevani booty, was brought by Hanuman, the kind of you all know Hanuman in Indian prehistory or mythology, who brought this herbal along with the mount kind of during the war with Ravana in the Ramayana history, you see, and this was used to bring Lakshman back to life, you see. That's how the story goes, and perhaps on the background of truth, you see. Subsequently, of course, in the history, the treatment of cough and breathlessness, fumes of different herbs have been used, such as Dhatura in particular, you see. This had great cough relieving properties, and almost for 5,000 years, and it has been used in most ancient cultures in India, China, Egypt and Greece, and so on, you see. These are the two very commonly used plants or herbs for different kind of therapeutic and habituating effects. For example, Dhatura and tobacco leaves, you see. Dhatura has been used in relieving pain. Ether and nitrous oxide have been used recently to induce anesthesia in surgical operations during the 19th century and so on. In the Middle Ages, people, or the warriors in particular, they used to carry sponges with the kind of with the drug squeezed in, and then it was the drug was squeezed into the nostrils for quick relief of pain, you see. So these are the kind of historical backgrounds of different types of inhalational drugs or herbs which had been used. And in modern times, of course, the smoking of cigarettes, tobacco, cannabis, marijuana and other habituating drugs is you all know. And of course, the last in the line are the electronic cigarettes or the vaping, you see. Tobacco, of course, has been used as cigarettes, bidis, pipe, chillum, hookahs and so on. Many different forms of tobacco have been used in particular in this country as well as in Southeast Asia. More modern development, of course, regarding the treatment of airway disease came into the 19th century when the asthma cigarettes were used, you see, and you can see here the advertisement for different kind of asthma cigarettes which were marketed for almost 200 years in the Europe, in particular in Britain, you see. I think that's for the history of inhalation. The modern aerosol therapy practically started in 1956 when the first inhaler, the Medihaler Epi, as you can see in this advertisement at that time, that became available. And rapid developments, of course, took place in this inhaler. Before this also, there were different kinds of inhalation techniques were used for about 100 years, but the modern inhaler with which we are familiar now, that's what you can see here in this advertisement, you see. Now, one important thing is to see the pharmacokinetics of inhalation, which I had just mentioned earlier. Importantly here, you can see here in the middle diagram, the blue, once there is a slow inhalation, the drug goes into the lungs directly, but 15 to 20% of inhaled drug is deposited in the lungs. You see, that is one problem with the inhalation route, that a small quantity of drug reaches the lungs, although different methods have been designed which will come to later in this talk itself, you see, to increase this inhalation in the lungs, you see. Then of course 80% is swallowed, and then of course it passes through the liver, and then some of it may go to the systemic circulation, and then through the standard route of liver, GIT, etc., it is excreted in the urine. Importantly is to know that the drug which is deposited in the lung, by and large, it bypasses the first pass metabolism in the liver, therefore the airway effects, you see. Now, what are the diseases for which inhalation therapy is indicated, you see? I am sure you all are aware and must have used these drugs for different diseases in one or the other form by now. The inhalation therapy is the first line treatment for airway diseases such as asthma, which is characterized by chronic airway inflammation. Asthma, incidentally, is the most common respiratory disease which is encountered in both adults and children, especially in the younger adults, teens and children as well. And there is chronic airway inflammation, as we all know. The second important condition for which the inhalation route is preferred is the chronic obstructive pulmonary disease, which again you all know is a chronic progressive disorder of the airways, largely in smokers, but non-smokers are also likely to develop if they are exposed to the risk factors of COPD, you see. Then there are other different conditions of the airways like bronchitis, bronchiolitis, and alveolar conditions like emphysema, in particular for small airway dysfunction. So the inhalation route is preferred, and we now have different kind of inhalers which deliver the drugs for the smaller airways as well, you see, and we'll come briefly to those issues subsequently. So these are the three most important indications for the inhaler therapy. Not only that, it is also a supportive therapy for respiratory symptoms, sometimes for chronic cough, wheezing and shortness of breath of any cause, you see. People are using these for symptomatic relief both in children as well as in adults, you see. For example, children who have refractory cough, chronic cough, inhalation route sometimes gives a better relief than the standard cough suppressants and lozenges, etc. You see. Then there are miscellaneous disorders, you see. It is not only the airway disorders like purulent tracheobronchitis and alveolar infections, you see. The infections, these are also become important, you see, for use of drugs, antibiotics in particular, through the inhalational route. You know, a lot of antibiotics these days, especially sometimes in the ICUs and other emergency conditions, which are used for which are used as nebulized forms, you see. Inhaled pentamidine was very commonly used for pneumocystis xerovasii pneumonia in patients infected with the human immunodeficiency virus or HIV infection, and still remains a drug of choice, although fortunately one sees relatively less and less cases of pneumocystis xerovasii infection because of effective treatment available for HIV infection. Then chronic lung infections with Pseudomonas aeruginosa in patients with cystic fibrosis and even with non-cystic fibrosis bronchiectasis, you see. So that is another important indication. So when the Pseudomonas is almost a kind of resident microorganism in the bronchiectatic cavities, you see. aerosolized antibiotics, they achieve better results. Liquefaction of thick viscid bronchial secretions, you see that many drugs are used by inhalation here, like even saline solution, hypertonic saline, and then mucolytic agents and so on, you see. Management of hyperkalemia, also you see, inhaled or nebulized salbutamol is frequently used. And nowadays, of course, will come towards the end, you see that even other systemic diseases like even diabetes and so on, inhaled drugs are being tried, you see. So as you can see in this kind of Cochrane review database, you see that comparison between intravenous and inhaled routes, and you can see here that there is no difference really between the intravenous and inhaled routes, and I had shown you earlier in that pharmacokinetic graph as well. Practically intravenous route has no benefit as well as far as airway diseases are concerned, and the potential for side effects is much less, you see. Though, therefore, inhaled route is the preferred route because it is easy, it is safe, it has faster onset of action, and it is more effective than parenteral routes, including the intravenous routes, you see. Systemic diseases in particular, I was just talking, it is a kind of needle-free delivery system, you see. And a wide range of substances can be given through inhalation, from small molecules to very large molecules as well. There is a large absorptive surface area of the lungs, and there is a membrane, the alveolo-capillary membrane, which is very freely permeable, you see. So many drugs can preferably be given by inhalation than with the intravenous injection, you see. So large molecules can also be given, small size molecules can also be given, and it's a low enzymatic kind of system. You can see here, I have earlier said that it passes the hepatic bypass system. So more drug concentrations are available, and so the drugs inhaled through the lungs, they are devoid of the hepatic enzymes, you see, which normally would lower the concentrations much earlier, you see. And so the reproductive kinetics or absorption kinetics, they are in favor of the pulmonary delivery of drugs, because you can bypass the GIT or the first pass hepatic metabolism. The dietary complications are not there, there is no interaction with drugs, which is there with many oral kind of drugs otherwise. So it is kind of preferred for inhalational, for systemic disease as well, but I think that time has not yet come to replace a large number of drugs used for systemic diseases with inhalational deliveries. What are the factors which affect the pulmonary drug delivery? I think we shall go into a little detail of these factors, because these are important whenever we talk of inhalation. The most important is the physics of inhalation, you see, because the particles, that is what are important or inhaled. So the particle size in particular is important. The flow of the medium which is through which the particles are inhaled, the inspiratory effort of the patient, the particle deposition in the drugs, and I think some of the other factors which will come in the next few slides. Then there are device related factors which are very important, because inhalation is to be given by different devices, and the drug delivery also depends upon the type of device which has been used, you see. That is one factor which you do not encounter when we take the oral route, the tablets or capsules. It is not as important here. To some extent it may be important for the injections, but certainly it is more important, the device related factors are more important when we talk of the inhalers, you see. Then there are also patient related factors which are important, because I think we need kind of patient cooperation to the other drugs are to be administered by, for example, the oral route is relatively easy, patient can most of the times do it himself. The intravenous is done most of the time by someone else, by a nurse or by a doctor or a technician, and rarely by the patient himself, but certain, for example, for insulins the patient would be administering themselves. But inhalers, almost all the time you have to depend upon yourself, you see, except in case of very children or nebulization, as you know, which will come subsequently, you see. So therefore the technique and the use of the device are also important. The pattern of breathing of the patient, geometry of the airways, you see, that is another important issue, because the airway is not a straight kind of path, you see, which goes into the lung. It is a very kind of the dividing pattern, as you know. It causes a lot of issues as far as the inhalation is concerned. The disease severity is also very important, because if the severe disease, then obviously the patient's own effort becomes a bit difficult, you see. So we, I think, should know the two kind of definition, the vapors and the aerosols, you see. Vapors, as you know, is a substance in the gas phase at a temperature which is lower than the critical temperature, you see, like steam from water, you see. And this can be always liquefied, as you know, a vapor can be condensed to a liquid when the pressure is increased, you see. And it is also a physical principle that a vapor, both liquid and solid form, they can coexist. Liquid, solid and gas form, they can coexist, you see. So vapor is the gas phase of a temperature, at a temperature where the same substance can also exist in a liquid or a solid state, you see. I think the classical example always given in physics lectures is water, because water can exist in a liquid state as well as in a kind of vapor state, the steam, and in a solid state, the ice, you see. And what is an aerosol, which is an important issue in inhalation therapy? Aerosol is a suspension of tiny particles of liquid, solid or both within a gas, you see. So I think that is what is that the liquid aerosols, they become important in case of inhalation, especially with the meter dose inhalers, which will just come in a few in the next few slides, you see. The second important kind of physical principle which governs airways, the inhalation, is the airways geometry and particle deposition. You can see here the airways consist normally of a branching system, you see. For example, from larynx, trachea, it divides into the two main bronchi, and then of course further subdivides into bronchial divisions and so on, you see, the bronchioles, primary, secondary and tertiary bronchioles, and finally into the alveoli. So whenever the aerosol is administered into the respiratory tract through the mouth, it goes obviously into the larynx and then into the trachea, and thereafter it moves into smaller and smaller airways at each bifurcation. So whenever the aerosol faces a bifurcation, obviously it faces a surface, and on the surface some particles will get deposited whenever they reach a point where the distance from their center to the surface is less than their radius, you see. If that distance is decreased, obviously the particle will move by either gravity or by other factors, you see, because of the shape, density and hygroscopicity, it will get deposited on the airway wall, you see. So, there is a variability of regional and total deposition of air of the particles into the lungs, and as it goes further and further, divides further and further, the deposition kind of decreases, you see, because maximum deposition will be there in the main pathways, you see, the trachea and the main bronchi, and subsequently at each division, you see, the some particles get deposited. And you also know it will depend upon the breathing pattern, you see, whether it is a smooth breathing pattern, because in a patient who is breathless, like a patient with acute condition, acute emergency, whether it is a COPD patient or asthma patient, then it is not a kind of linear flow which happens, you see, in the airways. In a normal person, the flow of air is linear, but it is turbulent air flow in a person with the breathing difficulty. So, the deposition is always irregular, it goes on irregularly within the lungs. It will also depend upon age and health and patient's physical activity. So, all these factors will determine the deposition of the particles in the respiratory tract or airways. And this is a very kind of standard picture, you see, or a table which you are familiar with, that the lung deposition depends upon the particle size, you see. The larger the particle size, the more proximal is the deposition, and very small amount of particles would reach the periphery of the lung. So, you can see the particles which are more than 5 micron are deposited by impaction in the oropharynx, and so they do not even get inhaled in the respiratory tract. So, larger particle size, dust size, for example, from air pollution and other things, you see, they are mostly deposited in the oropharynx and do not reach beyond the vocal cords, you see, and they are therefore swallowed in the GIT, you see. On the other hand, particles which are less than 5 micron size or fine particles, they have the greatest potential of reaching the lungs, you see, and that is what they are more likely to have the effect on the airways. As you can see that the less than 5 micron and less than 1 micron, they will go into the lung periphery, you see, and some the long, I think you can see here on the right side, you see, whatever, that the most particles of 0.1 to 1 micron diffuse by Brownian motion and deposited when they collide with the airway wall. And if it is a very small, fine, less than 1 micron size particle, they are even exhaled, you see, they may not get deposited at all in the lung if they are very, very small, less than 1 micron size, you see. So, some of them may get deposited in the peripheral airways, and this has become important in some disease condition, in the small airway diseases and so on, when you need very fine particles or ultra fine particles which can reach that area of the lung, you see. Before we come to those issues, I think the evaluation of drug deposition in the lungs can be assessed with various methods. Most important here is the gamma scintigraphy, which you can see here on this diagram, the left side, that the drug which is inhaled, you see, with the help of it is kind of pre-labeled with a radioisotope which emits gamma radiation or gamma rays, and then the kind of this is with the help of a scintigraphy, it is it is measured, it is photographed, and it is possible to visualize the distribution of the inhaled drug, and you can see here which is the area where it gets kind of deposited to a maximum concentration. Of course, that is generally important during the drug development technique methods, because whenever there is a new device or a new drug, you want to see whether it is really deposited in the lungs and adequately or not. And blood levels of the drug can be done, urinary levels of the drug can be done, and they have their own importance in the drug development, whether the because we want the drug to be deposited in the lungs to a maximum effect as far as the airway disease or lung disease are concerned, you see. So next we come to the inhaler, you see. Once we know these principles of inhalation and drug deposition, I think the most important is the device here. And the device, inhaler is a device obviously which used to deliver the aerosolized drug into the respiratory tract. And classically, I think you know that there are 4 types of inhalers: the pressurized meter dose inhalers, and in this category there are also the ultra fine particle inhalers, you see. I was just talking earlier that ultra fine particle inhalers are important for the drug delivery to the most periphery of the lung, you see, for small airways or even I think you can say the alveoli sometimes for deposition in the terminal part of the airways. Then there are so the dry powder inhalers, the DPIs, with which you are all familiar, breath actuated inhalers and soft mist inhalers. We'll discuss briefly about these issues, and finally nebulizers, you see. And then there are add-on devices, the spacers and the face masks, you see, which we'll briefly discuss. The important differences in all these kinds of inhaler or different type of devices is the ability of the patient to use different inhalers, and then the difference in cost, convenience, and portability, and the particle generation characteristics. So they are different with different types of inhalers, you see. I think you all are familiar with different types of inhalers which are available and have been shown here. Some of it, of course, there is a plenty in the basket in the market these days. First of all, the meter dose inhalers, they are compact instruments through which deliver a meter dose with each inhalation, you see. And most of the MDIs contain 200 doses. They are portable, you can carry in the pocket or in a purse. They are convenient to carry, quick to use. They are also economically in the long run, and they have long track record, you see. We know they're more than 40 years, you see, the 50 years in fact, or as I said earlier, 56 was the first inhaler, and that was the meter dose inhaler. So we have now almost 70 years experience with MDIs, you see. The disadvantages with the inhalers are that they're highly technique dependent, you see, because that is one factor, that the coordination between patient actuation and inhalation is very important, and that is the most important disadvantage or kind of factor against the MDIs. Slow and deep inhalation is required, because the patient takes a rapid inhalation, the vocal cords will close and the drug will not really reach the lungs, you see. Breath holding is important, and if the technique is very bad, you see, it is also possible that no drug goes into the lung. This is a common complaint with many patients. See, they will just kind of activate the inhaler, and the whole drug remains in the mouth and deposited there, and hardly any drug reaches the lung, you see, where the action is required. So I suppose that is what is the most important issue with which we are familiar, and will discuss in detail. Then they are also require propellant. All the inhalers, the meter dose inhalers, they required a propellant to kind of propel the drug particles. And propellants have their own disadvantages. You know, the classical CFA propellants had kind of the ozone effect and so on, you see. So they involve the use of MDIs involve multiple steps. I won't go into the detail, but you have to remove the cap, shake the inhaler, hold it upright, and keep in your mouth and inhales, kind of close your lips around the inhaler, then activate. And the moment you activate, I think that is when the inhalation has to start slowly and deeply. That is what is the most important step and crucial step where the problem comes, you see. If the patient has pressed it and does not start inhaling immediately, slowly and deeply, it does not go into the lungs. So that is, I think, what the multiple steps involved. And there are many errors and problems, and many studies have been done. In one of the study, I mean, at that time there were 20 studies with more than 3,000 patients, and the misuse was very common in this country. In fact, we have repeatedly now seen in our own experience, and multiple publications are there, that there is a kind of misuse, you see. Although in some of the studies says 38%, but in this country in particular, the inhalation problems occur with almost 80 to 90% of patients. You see. Poor coordination, short breath, rapid inspiration, and inadequate or no shaking of inhaler, and all kind of this is what I think was important publication here. Almost 30 years back, you can say with the change in FEV1 was seen at 30 minutes or 90 minutes, then the bad technique, and with good technique it can be improved significantly, you see. So improvement in lung function will depend upon the technique of the inhaler. So same patient, same inhaler, same doses, but with better technique, the drug effect is much better if the technique is better, you see. So poor inhalation technique leaves a lot, because patient loses confidence finally in the therapy. For patient, it looks that the drug is not effective. The fact is that poor inhalation technique, inadequate drug deposition. So it is a very kind of vicious cycle which happens with poor technique, you see. So what is the remedy? The remedy is the kind of one is that repeated patient education and training. That is what is most important. And then the second is the use of spacers or other alternate devices. That breath actuated devices have been used, and then finally are the dry powder inhalers. Spacers, I think they have been very commonly employed because they keep the particles within the space. Coordination problem is solved, and they reduce the oropharyngeal deposition in the mouth, reduces side effects. So MDI plus spacer is almost as effective as nebulizer, I suppose. That is very important. So inhalers, in fact, almost always we never use inhalers, MDIs alone, you see. And there are different types of spacers available in the market. They are also useful for children, for very old people, and for acute attacks, etc. I think so. One should never rely on inhaler without a spacer. The second important method to avoid this problem is the availability of autoinhaler or breath actuated inhalers. They are also helpful in kind of getting rid of this problem of coordination. Here the patient will inhale only if he inspires, you see. So even, and they can be activated at a low flow rate of 20 to 30 liters per minute, which is most of the time is always there even in severe condition, you see. And they have a high drug deposition rate, and fortunately most of the inhalers now are available as autohalers, you see, and they at least they take care of the in coordination problem, you see. And this you can see here, the drug deposition increases significantly with autohaler. The second important are the dry powder inhalers, again introduced several years ago, and there are no propellants in the dry powder inhalers. They are again like breath actuated inhalers. The delivery of the drug is here initiated by the patient himself, you see. And many different kinds of DPIs are available: capsules, blisters, reservoirs, and others, you see, single dose, multiple dose, rotaheads, etc., are available, you see. But there is a kind of, you can see here that the DPIs, they contain drug plus lactose here, and once the patient inhales, there is deaggregation of these things, and the drug is inhaled while the lactose part is deposited in the mouth. Generally they require a little higher inspiratory flow rate. I think that is one disadvantage, because the deaggregation of these particles, as you can see here, would occur only with the inspiratory flow of about 60 liters per minute or so, you see. The DPIs are easier to use than MDIs. They are breath actuated, no coordination required, they are compact and no problems. But they are inspiratory flow dependent, so may not be useful in older patient, in severe disease, in severe COPD or in acute attacks. So some of them, they cannot fit in all ages, some need loading. They are also more expensive and moisture sensitive. They are there, you see, some of them. In fact, is a common complaint, especially in this country during rainy season, the drug effect, that they find it difficult to inhale. They contain lactose, etc., and the greater pharyngeal deposition, you see. And the dose is more, you see, almost double the dose of MDIs, you see. I'll skip that, I'll come later, you see. So the selecting the right device is most important, and it depends upon the age, IQ of the patient or understanding of the patient, disease severity, inspiratory flow rate, acute situations, and local side effects, you see. And what is important for us to determine what kind of inhaler to use, and that would to which patient, you see. Of course, it generally, I think an important study was done here where which concluded that clinicians choose inhaler device by personal differences or personal preferences more out of instinct than science, you see. I think it is important to learn here is that you should choose your inhaler selectively depending upon the patient choice and so many factors which I have discussed earlier, you see. There is no perfect inhaler. One cannot either say MDI or DPI, which both are have advantages and both have disadvantages, but one has to choose wisely, you see. Third fact, kind of one can choose between to avoid errors with DPIs and MDIs is to use nebulizers, which is a air driven pump, useful in patients, especially in very small children, elderly people, and people with disabilities who cannot use inhalers. I think in emergency situations, of course, nebulizers are useful. Nebulizer is a very important issue and a big issue. I'll discuss in detail in the next master class, you see. Then there are soft mist inhalers. which are becoming available, which are again liquid based inhalers. They produce fine mist more slowly. They are like, they are not like MDIs that you deliver it once. So they deliver the treatment for a short term care, you see. And these are the basically in next few years I am sure more and more soft mist inhalers will be developed, because they kind of give the delivery in a softer, not single, like MDI would deliver the drug in a single step, you see. Here the drug is available for few moments, you can see here, and so inhalation is better, the drug delivery is better. So for the time being, of course, soft mist inhalers, number one, they are costly. Number two, they are not available for all the drugs, but in due course of time, we'll find more and more, you see. Few slides about inhalational drugs. You know, plenty of the drugs can be used for, most important for asthma and COPD are bronchodilators, like beta-2 agonists and anti-muscarinic agents, then corticosteroids and combinations, you see. Other drugs we are not concerned for the time being are the antibiotics, mucolytics, and so on, you see. Short-acting bronchodilators like SABAs and SAMAs, short-acting beta agonist and short-acting muscarinic agonist, salbutamol, levosalbutamol, terbutaline, ipratropium, and other combinations, ipratropium and albuterol combination. They are for SOS effect, immediate effect, but they cause dry mouth, headache, cough, tremors. You know, these effects are of all beta agonists and so SABAs and SAMAs. Then we have long-acting bronchodilators like LABAs and LAMAs, like formoterol, most commonly used formoterol. Then we have solmetrol, indacaterol, oladetrol, and so on. I think there are multiple now, and different LAMAs. Tiotropium is the oldest one, better one. Glycopyrrolate, and then there are aclidinium, revafenacin, and umeclidinium, and so on, you see. So I think every drug has its own uses and advantages and disadvantages. We are not going to discuss them today, you see. Side effects, they can also cause the dryness of mouth, that is very important, dizziness, tremors, running nose, etc. Some of these side effects are there. Then there are inhaled corticosteroids, which is the most important drug as far as asthma is concerned. And again, like other inhaled bronchodilators, the corticosteroids are also many: beclomethasone, fluticasone, budesonide, cyclesonide, mometasone, and so on. They are long-acting, low dose, medium, high dose, etc., etc. And the side effects are few, unlike the systemic side effects of corticosteroids, which are used through oral or parenteral routes. Here, mostly it is called on local side effects like redness, thrush, dysphonia, etc. You see. Then, of course, the low, medium, and high dose inhaled corticosteroids, they each have their own problems and side effects. But I think it is important to know how much is the inhaled corticosteroids in a particular inhaler, because the effect and the side effects will all depend upon the dose which have been used, you see. Combinations are important here because many of these, especially the long-acting, the LABA-LAMA combination, for example, long-acting and long-acting beta agonist and long-acting muscarinic antagonist, they have their own the combination like aclidinium and formoterol, tiotropium, oladetrol, albuterol, ipratropium, glycopyrrolate, formoterol. I think there are many available now. I may not have listed all of them, but LABA-LAMA combination earlier were not available easily in this country. Now they are available in plenty, you see. We, of course, have more commonly available the inhaled corticosteroids and long-acting bronchodilators, especially the LABAs, you see. Budesonide formoterol has been used for almost several decades. Fluticasone salmeterol has been used for decades, and they have proved the test of time. They are very useful. Nowadays, we have also the combinations of fluticasone and formoterol, fluticasone vilantrol, formoterol, mometasone, and so on, you see. Again, we are not going into the details of these drugs. What is important is to know that the combination inhalers are very useful. And as you can see here, this is what is the combination of ICS and LABA, which is more effective than either component alone. I think that is that was very important finding few decades ago, you see, that for use in asthma, it is the combination of the LABA and ICS which is more effective, because you can see here corticosteroids act on the glucocorticoid receptors for their anti-inflammatory effect. On the other hand, LABAs act on they cause bronchodilation, the beta receptor expression, you see. So they act on different receptors, so they are in a way additive to each other, you see. More importantly, however, they augment the effect of each other. I think that's what you can see here, that they augment the effect. The corticosteroid augment the effect of LABAs, and LABAs augment the effect of corticosteroids. So their effect is also complementary. It is not just additive, but it is complementary to each other. So that is what is important. So that combination remains the standard as of today for use in asthma, you see. Nowadays, of course, there is some evidence in the recent past, you see, that even in COPD, there is necessity to use inhaled corticosteroids, and that has brought the triple combination in the market, you see, the LABA, LAMA, and inhaled corticosteroid combination. And fortunately, in India as well, we have all these combinations by some of the companies. We have fluticasone, vilantrol, umeclidine. We have beclomethasone, formoterol, glycopyrronium, budesonide, glycopyrronium, formoterol, and glycopyrronium, formoterol, and fluticasone combination, mometasone, formoterol, glycopyrronium. So I'm not going into the merits and demerits of the drugs because that is not the issue for this class. What is important is to know that different drugs, you see, the bronchodilators as well as inhaled corticosteroids can be delivered by different methods, and not only individually, but they can be combined, and combination inhalers, they have their own important kind of effects, you see. So in summary, I will say here that inhalation is the second most common form of delivering drugs and inhaler medication throughout the world, you see. So after oral pills, tablets, capsules, etc., inhalation route is the most important route, and inhaler devices are very important, you see. That is the most important, and in fact, device development is now even more important than the development of new drugs. And we also know that the perfect inhaler should have at least the following characters. It should have a small particle size, minimum of instruction should be needed, and large patient satisfaction should be there, which should be easy to carry along because these people are kind of mobile people, you see, the asthma patients in particular. So they should be able to carry the drug and induce excellent patient compliance, perfect deposition in the lungs, and no side effects, you see. So that's all I want to say here. Thank you very much. Questions? We have some questions. This is an important question, that are inhaled corticosteroids safe in comorbid heart conditions? I think that is one important advantage of inhalers. They are most of the time they are safe in in the presence of heart condition. The only issue sometimes is with the drugs causing, like especially the bronchodilator drugs causing tachycardia, palpitation, etc. And one can perhaps see that what is the heart disease and for what they are using it, you see. So the drug can be modified, like, because the inhaled corticosteroids of course are safe. Sorry, I just mistook it by thought it is inhaled drugs. The corticosteroids are safe. There is no problem with the corticosteroids, even in not only heart conditions but also in diabetes, you see, when fairly safe, because very small amount of drug goes into the systemic circulation. Can inhaled corticosteroid increase the chance of pneumonia? This fear was there with inhaled corticosteroids, especially in COPD. But then people also realized that there are trials now available which show that the latest trial was there which suggests that the risk of pneumonia is very minimum, you see, and if pneumonia occurs, it is practically because of the COPD rather than the use of inhaled corticosteroids. So I think in the latest guidelines also, the gold guidelines also recommend by and large that you should use the for all categories where exacerbations are likely to occur, one should use inhaled corticosteroids as well. So I don't think that risk is really significant, you see. Should we use synchro-breathe inhaler as compared to traditional inhaler, which is better? Well, synchro-breathe is certainly better in one sense that it is a kind of patient actuated inhaler, you see. So here the coordination problem or incoordination problem is not there, you see. So the drug will be delivered only when the patient inhales it. So it is certainly better. The only thing is some patients do complain local side effect, you see. Because you cannot use them with spacer. The other MDIs can be used with spacer, and some people who feel happy with spacer because it does not get locally deposited. So those patients who have problems of local deposition, throat problems or hoarseness of voice or even flush, the candidiasis, they can perhaps use the preventive steps, but otherwise synchro-breathe is always better in that sense. But one should always wash the mouth properly to avoid the local deposition of the drug afterwards. Many patients complain of harsh throat after taking inhalation. I think that is what we were discussing just now, that harsh throat after taking inhalation is because of the drug, you see. One is the cold freon effect, which they say, because when you take MDI directly into the mouth, it causes a kind of cold sensation, you see. And the other is kind of the irritation, throat irritation. And third would be almost kind of development of candidiasis, local candidiasis. So they can be always taken care of. One, of course, is after each inhalation, one must do some local gargling or take some water or the things, warm waters, you see, just rotate in your mouth and then inhale it, ingest it, you see. That would avoid the deposition greatly to a large effect, you see. So after each inhalation, this is a must to wash the throat, you see. Small particle size inhaler like Niveoli, which have been particle size are effective in small airway disease, and small particle inhaler the future of inhalations. Yes, certainly I have already referred here, and we'll discuss the small airway disease sometimes later in one of our class. But for small airway disease, your ultra fine particle inhalers like Niveoli, etc., they are always better because they cause see the drug reaches there, because the smaller these particle size, the larger the penetration of the drug in the airways, you see. So if the particle size is really fine or ultra fine, it will reach the most distal part of the respiratory tract or the small airways. So that I think is very important, and for small airways, obviously you have to use all the way. Which type of device in your opinion are most easy for patient to understand use? I think that is a very personal choice, you see, not only the doctor's choice, but also choice of the patient, you see. I can't say that one or the other patient actuated inhalers are certainly better, you see. The patient actuated, like the synchro breathe you were mentioning here, you see. So though they are important, but otherwise most of the time what is the education of the patient, intelligence of the patient, understanding age, disease, is there any local disability, how much is the severity of condition. So depending upon these, for example, very old people, they will not find the MDI is easy. People with a lot of deformities, disabilities, etc., they will not find the use of any. Children do not understand sometimes the use of rotahilar, very small children, you see. Parent have to advise, they give them the MDIs with spacers, etc. So other patients, I think which they choose is also important. Some people patient feel better with the MDIs, some patients feel with DPIs, so one can choose between the two. I will not say that one is better, always better, but I have shown the advantages and disadvantages of both the types, you see. The DPIs, they require higher doses. In fact, in our practice, most of the time we use MDIs, you see. But it is not necessary that we will use MDIs all the time. MDIs with spacer. We have a trainer which keeps which all explains to the patient repeatedly that this is how MDI is to be taken with spacer. But that does not mean that DPIs are not useful. So finally I come to the same which I've shown you studied here, you see, study which were done on several hundred patients, you see, that finally it is the choice of the patient and the choice of the doctor between the two types of inhalers, you see. Thank you. Thank you very much.